In this paper, we looked at how we introduce a system for managing open hand injuries as a semi-emergent or semi-emergency case, and to look at outcomes in terms of infections. About 20% of attendants at the emergency department are hand injuries, and traditionally we have been used to the idea that all open hand injuries are required to have a surgery within 6 hours. Our question was, can it really wait, and would there be any increase in infection as a result of waiting for hand injuries to be operated? So we had a system in 2011, which I introduced at my hospital. We call the P4 system for hand surgery, where all cases that were seen in the emergency department were reviewed by a hand specialist who would then assess the patient in what we call a hot clinic in the emergency department itself. They were then assessed to be whether they were stable. If they were stable and if it's a simple procedure that we conducted in the emergency department, they would be treated there and then referred to outpatient care to continue the care. However, if the patient required admissions based on our criteria, which is mentioned here, which is replantation, revascularization, infection, dislocation, polytrauma, and mutilating injuries, then they will be admitted. And the plan was can it wait, or does it need to have an emergency surgery, which we again had criteria for that. Then they will be operated in the main operating theatre or the day surgery and discharged. However, those that can wait, they will be then put on a dedicated list in a day surgery suite, where they will then be operated by a specialized team of individuals. All patients are counseled, and the counseling is documented, and they are brought into the day surgery within 3 days of the injury. This was the treatment protocol in the operating theatre for all open wounds. The surgical debridement was performed. They were given antibiotics, and then they were discharged on the same day with a follow-up in the outpatient clinic. And they are reviewed within 2 to 5 days. And the simple cases were followed up for 6 weeks, and more complex cases were followed up to 3 months. The P4 systems was evaluated in a previous assessment and was given an award as a clinical improvement service. It reduced admissions into hospitals waiting for surgery. Man-hour saving in emergency department was significant, and there was a reduce in the cost of admission. The wait for the surgery was in the comfort at home, and there was an improved utilization of the day surgery operating theatre suite, and every case was supervised by a consultant, and the intervention was performed by a dedicated hand surgery team. The aim of this study was to see whether delay in timing to surgery for open hand injuries resulted in increased infection. Because of this study was the population was open hand injuries, the intervention was semi-emergent surgery in a dedicated theatre, and comparator was surgery being done within 6 hours, and the outcomes were the occurrence of infection, and the study design was a retrospective cohort study. These were our inclusion criteria. Basically, any open injuries of the hand which were treated as a semi-emergent surgery was included. These are the various ethics approval was obtained, and the type of surgery that we did for all these cases were as listed here. And the complex reconstruction means that there were repair of 2 or more tissue components, and the fixations we used were from plating to KY immobilization. The statistical analysis that we used in our study was basically for ordinal data. We used median and interquartile range. Categorical data was evaluated with percentages and descriptive statistics. And univariate analysis was using crude odds ratio, and as the odds ratio with a confidence interval of 95%, a p-value of 0.05 was deemed statistical. We had 232 patients that were recruited into this study with a median age of 33. Majority were males, and majority again were performed under local or regional anesthesia. This is the distribution of the type of surgical procedures performed on the patients, general common types of surgery, and the time to surgery here shows how long does it take. No more than a majority of patients were done within 100 hours of the time of injury. And this is the demographics of our population that underwent surgery, and we see the use of antibiotics and the post-op use of antibiotics. So the significant results of this study shows that the time to surgery was fairly quick, and in these three cases where there was post-operative deep-seated infection, this is the details. So if you look at the time to surgery for these three patients, they were within 47 hours, so they were not more than 48 hours from the time of injury. And so the cause of infection cannot be attributed to a significant delay in surgery. And the time to surgery for the study population as a whole, you find that there was no statistical significance between the infected group and the non-infected group. Like I said, the infected group, the time for surgery was within 19 hours, whereas the non-infected group was 46 hours, the mean. So the overall treatment cost, we analyzed the value of this new system. The cost for, like for example, we took nerve repair as compared to admissions and as a day surgery. There was a slight difference in the cost, being cheaper by sending them home and coming back as a P4 using our system. So the summary of this paper, from our experience on the use of the P4 system for the management of open hand injuries, there was no association between the administration of antibiotics pre or post-operative and infection rates, but you must realize that the difficulty in generalizing this based on the low number of infections, there were only 3 cases, and so that has to be taken into account, and other confounding factors were not taken, as this is a retrospective study. Age is also not associated with infection rates, but it significantly reduced waiting time for admission. Treatment cost was also reduced, and the surgery was performed during office hours surgery with an experienced surgical team which provided the care at an expert level, and they also facilitated pre-op screening and planning for surgery, as the patients were counseled and assessed in the emergency department prior to arriving for surgery. The limitation of this study is obvious, that it's a retrospective study, and the low number of positive cases, again, of infection are difficult to do analysis, statistically significant. And however, the comparator here, that we did not compare with our own cases which are done within 6 hours. However, we use the published data as our comparator. And in the published data, the infection rates of open hand injuries were up to 14 hours, and ours had an infection rate of 1.3 hours, which are comparable. In fact, is lower. Majority of our cases were done, 85.3% were done within 72 hours of presentation, because our delivery of quality of care with the P4 system, that no patient would wait more than 3 days for the surgery to be done.